Hi everyone, my name is Gianna Calabrese. I'm a program coordinator with Peer Assistance Services, and I coordinate the SBIRT School-Based Health Center project. My colleague, Sam Borden, with the haunted house in the background, will be here today as well to monitor the session. Just so you all know, the session is being recorded, and if you could please keep your mics on mute, that would be great. We realize Zoom fatigue is real, but if you feel comfortable putting your video on, that'd be wonderful. Feel free to ask questions in the chat box throughout. We'll also open up a section of questions at the end. There will be a post survey at the end for the SBIRT School-Based Health Center project participants, so we'll drop that in the chat box at the end. And now just a little bit of background about Dr. Brett Harris. Dr. Harris is a clinical assistant professor at the University at Albany School of Public Health, where she currently teaches a course on suicide prevention. Dr. Harris recently accepted a position as a senior research scientist in the public health department at NORC at the University of Chicago, and she'll be specializing in behavioral health. Prior to her role at NORC, Dr. Harris was director of public health initiatives at the Suicide Prevention Office of the New York State Office of Mental Health, where she oversaw initiatives for schools, colleges, and communities. In addition to that, Dr. Harris has developed, implemented, and evaluated SBIRT projects in multiple settings, including school-based health centers, and she also conducts research on factors that impact adoption and implementation of SBIRT by school-based health center providers. So, Dr. Harris, I will turn it over to you to start. Thank you.
Thanks, Gianna, and thanks everyone for joining this session. Gianna was telling me that suicide prevention was the #1 topic that you guys were interested in for the learning community. So I'm glad to be able to bring this to you. And as Gianna was saying in my bio, I have real interest in early intervention for behavioral health issues in school-based health centers. And prior to my current position, I've been working for, I would say, about 6 years, trying really hard to implement SBIRT in New York State school-based health centers. We have a very large and diverse system in New York State. So there were challenges which led me to conduct some research to really figure out what those factors were that to adoption and implementation for something that's voluntary. So it's not something that we require at all in New York. And then, kind of moving over to suicide prevention, I saw a lot of similarities in the model of intervention in primary care and behavioral healthcare settings. A lot of similarities to SBIRT, and I just thought that with the intersection of substance use and suicide, that there's this is an opportunity to integrate suicide prevention into SBIRT. And, in my work at SBIRT, I know that, we want to increase uptake of SBIRT, and we wish that there were more there, but SBIRT's, I think, far more advanced than integration of suicide risk screening and intervention. So it's a real kind of, plus to be able to integrate suicide risk screening and intervention into SBIRT to increase its uptake. So I'm going to begin by just giving you a little bit of background, kind of at the public health problem of suicide. Just briefly here, you can see that suicide's been increasing in the U.S. compared to other kind of public health issues that have been getting more focus. And then, as we go along, I'm going to only briefly go over the data because I have a lot of other stuff to cover, but I want you to give some thought as to if there's anything in the data that surprises you or anything you think, yeah, well, clearly, yes, that's what I thought. Feel free to write that into the chat box and so we can have a little bit of discussion in the Zoom environment. And I'll pause after I finish with the data and we'll see what you guys had to say. So suicide has been increasing in every state. You can see in Colorado, there was a 31 to 37% increase between 1999 and 2016. But clearly this is an issue across the US. So the leading cause of death by age group in Colorado is, you can see that 10 to 14-year-old suicide is the #1 leading cause of death. And then for 15 to 24-year-olds, it's the second leading cause of death. And then by age, so basically, this is kind of the trend we see in really all states in the U.S., but we see it's lower among youth, but then it kind of increases a bit and peaks around middle age. And then I didn't break out the older adult category, but usually kind of increases again there with the oldest group of adults. But these rates are fairly high, particularly the 15 to 24-year-old category, 24.1 per 100,000. I have been doing all my work in New York, and this is significantly higher than what we have in New York, which really points to how important this is to address this suicide risk in school-based also. So the suicide rate's been increasing among those between 1999 and 2018 for ages 10 to 19 in Colorado. You can see more recently. So this is actually a trend occurring across the U.S. And you'll see in the next, how in the last slide, I was saying how the suicide rate is lower among young people, but this has been gaining a lot of attention, suicide prevention among youth, because the increase has been so great recently. And the greatest increase is among young people. I talked about the risk in middle age, but that risk, the increase it's actually kind of the percent increase, it's plateauing. So the issue and the increase is among youth, and you can see that increase is happening. The biggest increase in this time period is the more recent time period. So this is from the Colorado Suicide Prevention Data Dashboard, and you can see that kind of how it breaks down again, specifically in Colorado. And this is also pretty similar to other states in the U.S. in that the vast majority of deaths are among males and non-Hispanic whites. And then the dashboard provides some really useful information by county. And you can see, so the darker color means the greater number of suicides. So you can kind of see, where where you're located and how you compare kind of with the other other counties in Colorado. And then, so for circumstances, so what were the circumstances involved in the death? We could see more than half had a current depressed mood, almost half a current diagnosed mental health problem, about 40% ever treated for a mental health problem. So that's important to just see there yourself, because we always think that we try to link suicide with mental health problems or a diagnosis of a mental health problem. You can see more than half don't have that diagnosis. And a lot of times if they don't have that, they're not actually getting treated by a mental health provider. So that just leaves it open to, it needs to be addressed, identified and addressed somehow and by someone. Yeah, so you can see kind of near the bottom of the slide here, less than 30% are currently in mental health treatment. And now that we're talking about integrating this into the SBIRT model, and we're talking about substance use, how these are linked, there are specific circumstances that are specific to substance use, and almost 30% there was alcohol present at the time of the death. 20% had a reported problem with alcohol. 22% problem with the substance other than alcohol. Then 20% marijuana present. We all, we know that there's an issue, the opioid epidemic now. We have about 7% opiates present at the time of death. And then I pulled the national data here, but I just wanted to also stress that we're not only talking about deaths, but we're talking about self-harm. So this is self-harm is our closest approximation to a suicide attempt. It does include, not having an intent to die, but this is the best that we can do. But you can see among youth, they have the highest by far rate of self-harm. So this is definitely an issue. But of course, youth are, they're more resilient and young, and they better health, more likely to recover, and they're also have a family and they're at home, and they're more likely to be found and gotten help. So they're kind of more resilient to an attempt. And then females have the higher rate of self-harm compared to males. It was the opposite with the death. And just kind of to give you a picture of it, there are about 25 attempts for every death And then among youth, about 100 to 200 for every death. And then again, it's a much larger problem. So for each suicide, there are 147 people exposed. So maybe they know someone, they have a friend or a family member who died by suicide, and that really causes extreme grief and potential mental health problems, as well as other issues moving forward. And I just pulled some information from the Youth Risk Behavior Survey from the CDC from Colorado. So this is among high school students, grades 9 through 12, 2017, which is the most recent data. And they were asked about what occurred the 12 months prior to taking the survey. So you could see that about over 30% reporting feeling sad or hopeless, 17% seriously considering attempting suicide, 13% made a plan, and 7% attempted suicide. And those numbers are higher among females than among males. And the last thing here I wanted to point out too is the high risk among gay and lesbian youth. And unfortunately, they don't have data on transgender, but that's an extremely high risk as well. But you can just see how the darker green bars here, 60% felt sad or hopeless in the past year, 34% seriously considered attempting suicide, 31% made a plan, and 26% attempted suicide. All right, so I'm just I'd like to take a minute to see what you guys had to say in the chat box.
Brett, the first question that we had from Rebecca Doty was, what is Nevada doing to prevent suicide? Just a thought.
Does the Rebecca mean New York?
No, I think it was in response to the 1% decrease on the map that you showed of the United States.
Oh, okay.
Yeah, I was just curious if they are doing something different, progressive, or if it really has to do with reporting of numbers. Just curious for your thoughts.
Yeah, I don't know specifically, but my thought is that the numbers of suicide they probably have there is pretty low to start off with. So any kind of change in suicide would cause a rate fluctuation. So it's possible that would be it, because I think for the most part it's a across the board we're seeing the increase. Like I think all of the states are kind of struggling with it. So it could just be kind of the overall number of suicide, but I'm not really sure specifically what they're doing.
So then next question was, for the states who have experienced the least amount of increase, do you know if that's due to poor or underreporting or some other factors?
I think it's a mixture of factors. There's definitely issues with reporting, and it's kind of out of the scope of this presentation, but we're working on ways to improve surveillance of suicide and the systems that are being used right now. There's definitely a lot of data seepage, to say. As they're kind of like abstractors, and the way that data are collected is done by different people, and at the scene, and the data gets lost, it gets pulled from different people, and then it gets interpreted and then put into it. It's like a lot of different steps along the way, and it gets lost along the way. I think some states have more kind of comprehensive efforts. They have more grant funding, and they also have dedicated staff for suicide prevention. So that plays into it. And then another piece is that there's also different laws in place. So like I say particularly gun control laws. So New York State has the very strict gun control laws, and we have we usually hover around the lowest rate of suicide in the nation. So those kind of policies, and it could be what policies kind of got put in place in that time as well.
This one might be a little bit specific to Colorado for you, but the question was, El Paso County is home of the largest military bases in Colorado. Do we have any stats on how many of these suicides, especially the high suicides rates in Colorado, are affected or related by the military?
That might be, I don't know if Gianna knows, but there's the data dashboard may or may not have information on this. I know in New York, we have a data dashboard that we actually kind of based off of the one Colorado has. And we have veteran status at this point, but not necessarily active military.
Yeah, I'm not sure, but I will follow up with that question for sure.
So I just, what do? I can log in as my.
Sam, were there any other? Oh, one additional question from Amy was, shocking that 30% of LGBTQ youth in Colorado seriously considered suicide in 2017. Did I interpret that slide correctly?
Yes, you did. Yes. So that's, I mean, it's a very high risk group, which is kind of why I include a slide specifically there, even when I'm not touching on the data too much. And there are specific resources available. And it depends on, because we talk about there being more acceptance of, LGBTQ populations now, and there are, but there's still, there could be, non-acceptance in the home. There could be, the feeling of otherness, and then that self-stigma. And I've heard that a lot. Now that there's more acceptance and it's being seen as more normal, people, that identify as lesbian or gay may still feel that they don't belong, and that also, creates, major challenges for them. And there are specific resources available, like the Trevor Project. They have a few different. They have the Trevor Text, Trevor Line, that's the hotline, and they have Trevor Space as a message board. So a number of different services that are available for them.
Brett, I also just wanted to add to everybody on this call right now, we are going to be adding some resources from the Trevor Project in this year's booster training. So we'll be sharing those with you guys all soon.
Great. All right, so I just want to briefly touch upon the intersection of substance use and suicide. So what's going on here? So I just find this stat to be particularly, kind of eye-opening, that the suicide rate among those with an opioid use disorder is 6 times the rate of the general population. So the rate of the general population, 14 per 100,000 population. You already saw in one of my earlier slides that we were looking at the youth rate, 15 to 24, it was about 24 per 100,000. And so that's, significantly greater than the US average rate. And now we're talking about 87 per 100,000 for individuals that have an opioid use disorder. And we're in the middle of an opioid crisis. So people who misuse opioids are 40 to 60% more likely to have thoughts of suicide. And then those who regularly use opioids are 75% more likely to make suicide plans and twice as likely to make a suicide attempt. So we know that that's a specific risk. When we think about young people, that may be coming into your school-based health center, maybe opioid use isn't so high for that young population as it is for kind of like the youth who are a little bit older, kind of like young adults. But we also think, it is specifically an issue among that age category. And of course, you have the opportunity to do early intervention. And so 20% of suicides in the US involve opiates. And what I also want to point out is that 20 to 30% of overdose deaths are estimated to actually be suicides. So what we know is that it's hard to determine the intent in the absence of a suicide note. So pretty much if a suicide note is there, you can say that, the coroner or medical examiner will say, yes, that's a suicide. But in all other cases, it could be, be undetermined, or it could be an unintentional cause. And that's typically then given as a drug overdose, unintentional drug overdose. And we also know that many overdoses could be among individuals that don't actually have an explicit intent to die, but they don't care about the risks. So in a lot of conversations I've had with clinicians, substance use disorder treatment providers, or directors of substance use disorder treatment programs, they say that, when talking with patients, the patients know how risky their use is, particularly the opioids today with laced with fentanyl, anytime they use, they could overdose and die. And they know that. They say, yes, I know that. So in a way, they're not like, trying to take their own life, but they also don't care if that is the outcome of their drug use. And just, pulling it back to alcohol as well. So that's also significant intersection too, because up to 40% of lethal or non-lethal attempts involve alcohol intoxication. So what we know is that it's important to jointly address substance use and suicide. And there's been a term, a coin called self-injury mortality. So that includes both deaths by suicide and deaths by overdose. So we can say over 115,000 people died of self-injury mortality in 2018, rather than saying like, hey, there were like 48,000 suicides and there were, 70 some odd thousand overdose deaths. We can say in the 115,000 died by self-injury mortality. And suicide prevention could be substance use and opioid overdose prevention. So we know that we're struggling dealing with the opioid crisis. And I come from a public health background, and I look at kind of like the three things that they're saying to do to address the opioid crisis. And they're all, pretty far downstream when we talk about administering naloxone to overturn an overdose. So that's people that have already gotten to the point where they're misusing opioids and overdosing. Then we talk about safe prescribing. And then we talk about medication-assisted treatment. But maybe, so then, there are a couple of things here. So what I'm saying right now is that suicide prevention might be a missing element to addressing the opioid crisis, because right now we are struggling to do that. We saw a decrease in opioid overdose deaths, but then, in the most recent data, but the preliminary data for 2019 showing a 6% increase over the, that 2018 to 19. So we're not done with it. We're not on the way down. And the other piece is actually SBIRT, I think, because that's an upstream intervention possibly to address the opioid epidemic, by catching things early before it gets to opioid use and before it gets to opioid misuse. So we're working with young people instead of working with the people who are, misusing opioids and have the risk of overdose. So, substance use disorder treatment is catching on here. And in June 2019, there was a minimum required standard put in place for suicide care and addiction treatment by the Commission on Accreditation of Rehabilitation Facilities. And in the month after that, in July, Joint Commission followed. So for all hospitals and behavioral health facilities that are under the Joint Commission have to provide a minimum standard of suicide care as well. So I just provided a couple of links and little images of different reports that are really stressing and providing examples of how to address both substance use and suicide jointly. So now I'm just going to get kind of into the main piece here. So suicide prevention in school-based health centers. How do we integrate suicide risk screening and intervention into the SBIRT model? So I know you're all experts in SBIRT, but there are some, I'm just going to go over some commonalities here in screening. So you guys use the CRAFT 2.1, you screen for anxiety and depression as well. So we're going to talk about the Columbia screen, or the CSSRS, which you see on the screen. And you also, so we're going to be talking about the Just Health app that you use to, collect, to enter the screening scores and kind of move through the protocol when you serve youth. So I know you also have a self-harm question and a suicide question. So all of these questions kind of go right into the screening. And then based on the screening results, you provide a brief intervention. So in substance use, the Boston University has the brief negotiated interview. And then suicide, there is also a brief intervention. It's called the safety planning intervention. And that's a collaborative plan done with the trained provider along with the patient. And then there's the opportunity for extended brief intervention. So that's, if you have a student coming back into the school-based health center for an additional session of brief intervention to discuss substance use. You can also do that with suicide risk, and you can also do that, it's research shows you can do that over the phone with structured phone follow-up. And then there's referral. So I'm going to get a little bit into here to the CSSRS, which is integrated or in the process of being integrated into Just Health. So we call this either the CSSRS or the Columbia screen. So sometimes I try to catch myself when I'm saying it. So I say it one way, but I'll call it the CSSRS. So it in your Just Health app, it's going to be an 8-item scale. And it's really, so you say, you know, why do I need to ask all these questions about suicide? We already asked, like you might remember, you know, from your PHQ-9, you see a question about, you know, a wish to be dead in the past 2 weeks. And there's also you have another question on suicide. The importance here is that you need to know what to do with the response. And I know that when people aren't comfortable or familiar working with in suicide prevention, it's a scary thing. Someone says, you know, I wish to be dead, or I'm thinking of killing myself. It's like there's a panic there. You don't want them to do anything. So there's the kind of the jerk reaction to the knee-jerk reaction to you know, call 911 or, you know, hospitalize. We want to make sure that we use the care in the least restrictive environment, and we appropriately address, you know, identify what the risk level is. So the Columbia screen, the CSSRS, is provides a full range of ideation and behavior, including intensity, frequency, and changes over time. So we can find information about lifetime and recent suicidal behavior, and then we can get into like actual interrupted or aborted suicide attempts and preparatory behavior. And the basic thing, which I'm going to point out when I show the questions, is that you can discern between passive intent, active intent, and then having a method, plan, and intent, or I'm sorry, passive and active ideation, method, plan, and intent. So these are all yes and no questions. The first 2 questions assess general ideation. So the first question is passive, like I was saying. So that's basically the wish to be dead, as compared to the second question, which is active ideation and having thoughts of killing oneself. So I actually, you know, I'm thinking of killing myself instead of just having a wish to be dead. So difference between active and passive. And then having a yes response to having any thoughts of killing oneself. So the first 2 questions will then trigger the remainder of the questions. This is where we get into the presence of a plan, the intent upon acting on the thoughts, having both the plan and intent on carrying out the plan, and an actual suicide behavior. So both lifetime and recent. So you'll see kind of the difference between how the risk level will change based on, you know, just having basic thoughts, having a plan, and then actually having an intent to carry it out and so forth. So these are the questions that are in the Just Health app. And I know it's kind of small. I just took a screenshot of the questions, and I'm just kind of outlining, you know, what category they're in. So the first question, have you ever wished you were dead, or wished you could go to sleep and not wake up in the past month? So this is you know, we're all getting to recent here. So that's passive ideation. Have you actually had any thoughts about killing yourself in the past month? That's active ideation. So if the answer is no, it's going to be automatically skipped to question 7. So in the Just Health app, you click that, you'll get question 7. Question 3, have you thought about how you might do this in the past month? So that's especially asking about a method. And then when you thought about killing yourself in the past month, did you think of something you might actually do? So do you have any intent upon acting on this, on these thoughts? And question 5, have you started to work out or worked out the details of how to kill yourself in the past month? So this is do they actually have a plan how they're going to do it? And if no, you're going to be skipped to question 7, skip right over 6. So the 6 is asking about an intent to carry out the plan. So a plan plus intent increases risk. Then question 7, have you ever done anything, started to do anything, or prepared to do anything to end your life? So this is now asking about behavior. So this is ever, meaning lifetime. And then question 8 is asking more recent. So it's getting at lifetime versus recent. So was this in the past 3 months? So they may have had engaged in suicidal behavior. It could have been a while ago, could have been years ago. So it's important to know it's very high risk if it's recent, but if it's, it could be a lower risk if it's happened in the past. All right, so this slide was supposed to have been taken out, so I apologize if it wasn't. So when you get the slides after, you can just delete that. So this is how we break out the risk level. So these are all the questions, and it's really getting at the question intent. And then what should be the response? So you can see question 1 and 2, just having thoughts about suicide. It's low risk. It's of course, something that we want to do something about, but it's also, so it's pretty much providing a behavioral health referral. So that could be to, the social worker that you have at the, in your clinic. It could be, outside the system. That really depends on, what your protocols are. Question 3 is about having suicidal thoughts, but also with the method, but no specific plan or intent. So that's a medium risk. So that's a behavioral health consultation to consider patient safety precautions. And then we start getting into the high risk. You can see I put depends on having lifetime suicidal behavior. It just depends on how the person responds to the other questions. But the rest of them is particularly high risk. So having intent, I want to act, I'm thinking I actually have an intent to act upon my thoughts. And then having a specific plan, a plan plus intent, and then suicidal behavior within the past 3 months. So you want to have a behavioral health consultation and patient safety precautions. So what do we do after screening? And I'm gonna just kind of jump to the last bullet first here, and that similar to the SBIRT model. So if a youth screens negative for substance use, you still want to do something, right? It's like positive reinforcement. That's great that, you're not drinking or, you're not using drugs, and it's really encouraging, and I want you to, continue that behavior. It's similar, in a way for suicide risk, in that you want to provide something to them. So we call it universal precautions, providing them information. So if they are, because suicide risk fluctuates, and it's cyclical in nature. And the way we can convey this to youth in the right way, so that they have information at their fingertips if they find that they need it. We know that they're not always going to be coming into you at the time that they, something could happen, and they could, start having these thoughts. So there's the lifeline number, which is the suicide prevention lifeline. And there's also crisis text line, and there's a specific crisis text line in Colorado, which we have the information for at the end of this presentation, to make sure they have that, as well as any other information. Maybe tell them that they can come back into the school-based health center, or who they can contact. Just pretty much saying that, here's some information. If you, it's normal to be down, and, it happens to everyone. If you're feeling down, here's some, you can text this number if you have any, issues related to, school or relationships, depression, anxiety, that kind of stuff. They can use that. And then if you want to talk to us, come back in. So that's, one way you can address that. So for anyone, really, even people that are medium and high risk should also, be sure to have those hotline and text line information, as well as anyone that they can reach out to. So for imminent risk, do what needs to be done to keep the youth safe. So it could be an emergency evaluation, or it could be hospitalization. If not at imminent risk, again, review the crisis information, clinic after hours, if you have that, or if there's, services, outside in the community. And then, so a treatment, they should have a treatment plan that addresses suicidality directly, reduces risk factors, and improves protective factors. So we know that, a lot of times, if you don't have, specific training in suicide prevention, it's the immediate thought to say, well, if someone's thinking about suicide, we need to address the depression that's underlying it, or the substance use that's underlying it. But that there is suicide specific intervention, and that's because suicide, it can be so kind of immediate and cyclical, that needs to be addressed itself. Addressing the depression and the substance use can take too long to kind of mitigate the suicide risk. You want to increase your clinical contact with the student and do some follow-up and monitoring between sessions. And then there's the safety planning intervention before the end of this session. So I'm going to go over the safety planning intervention. I think that there might have been a question here. Okay, I think it was just the Trevor Project information. All right, so if there are no questions now, I'll just continue on. The safety planning intervention is really like the crux of this, what we would call, intervention or brief intervention for suicide risk. And this is something that the school-based health centers are definitely equipped to do, and would be, it's really kind of a strategic and really important place to provide this intervention. So when I say safety plan, like there are a lot of plans, and this kind of gets, the terminology kind of can get confusing. So the safety planning intervention is different from kind of what a lot of people talk about, a safety plan or a coping plan or a crisis plan. So this is actually a clinical intervention for those with suicidal thoughts and behavior explicitly. So it's to be used in a time-limited suicidal crisis. So as when we'll see on the next few slides, what's in the safety plan, it won't be applicable to those who aren't experiencing a suicidal crisis. So if someone who's not experiencing that or having thoughts of suicide will not really be able to, so whatever they develop, it won't be effective if they actually were to be in a crisis. So this is to be developed by youth who screen positive or at higher risk on the CSSRS. So it will just otherwise become just a form to complete if you don't know how to explain how and why it works. So the idea is that, suicide risk is cyclical in nature, and, so these urges come and go, and we want to keep the youth out in the community. People don't want to be hospitalized. They don't want to be, an inpatient or sent to the ED. A lot of times that they're afraid of that happening, and they instead don't kind of disclose when they're having these thoughts. They could take the screen and say no to the questions because they're afraid of what's going to happen. This allows them to have this tool in their toolbox to address these urges on their own. And it gives them really self-efficacy to be dealing with these things, because a lot of times, suicidal thoughts are chronic, and they will have to deal with that kind of throughout their lives. And this is definitely a tool that they can use. So it covers warning signs, reducing access to lethal means. It will become hypothetical if the youth doesn't actually have ideation with the method or a plan. So we see that, based on the responses, the youth will only get the safety planning intervention if they screen a certain way and answer certain questions on the CSSRS. Because if you have an overly general crisis plan, the triggers and the coping responses aren't necessarily the same when they're having suicidal thoughts as compared to like substance use, aggression, or domestic violence. Okay. All right, so there's a clinical intervention, and the results in the plan for when suicidal crisis emerges. So I kind of covered that in the last slide, when I was kind of talking over the last slide. It's how do you manage your feelings and stay safe? And it's really, it's supposed to be simple. It's when you're in a crisis, it's kind of hard to kind of think. Your problem solving diminishes. So this provides this really simple step-by-step format, and it improves coping and problem solving over time. So this will help. So collaboratively, the clinician and the youth go over these steps, and they determine kind of both cognitive and behavioral strategies to use during a suicidal crisis. And it is guided by, so the clinician guides it, but the patient as well as the family, it's always important to incorporate the family into this. they really generate the ideas, and it's kind of the clinician talking about, what do you think will work? What are the barriers to this, the challenges that you foresee, to kind of come up with the best plan. And I just wanted to point out that research, this does have, this specific safety planning intervention has research that backs it, both for youth, for adolescents, and for adults. So the 6 steps, and they're all, it's stepwise. So recognizing the warning signs, employing internal coping strategies. So this is basically what you can do on your own to cope. Socializing with others as a way of distraction. So not really talking about what the issues and the things that the suicidal thoughts, but just socializing. And step 4 is contacting family members or friends to help resolve the crisis. So this is talking with someone to get help about the suicidal thoughts. And then contacting mental health professionals or agencies, and then making the environment safe. So reducing access to lethal means, like, is there a gun in the home, making sure it's locked safely or, taken out of the home, or if there are pills, in the medicine cabinet, removing those. So to do this intervention, I have the steps broken down here with a couple of ideas of things that, you as a clinician can say to address these. So the first step is identifying warning signs. So what do you experience when you start to think about suicide or feel extremely depressed? And how will you know when the safety plan should be used? So then you also want to make sure that you've heard the youth correctly, and that should also show that you're listening. It's like a form of a summary to list the warning signs using the youth's own words. So the next step is internal coping strategies. So you could say, what can you do on your own if you become suicidal again to resist acting on your thoughts or urges? And then what's important, it's like to really ask them, how likely is it that you would do this in a time of crisis? Because you will get responses of, saying things that, they really won't do. And you want to make sure that it's kind of going to be as usable as possible. And you'll see that there's, follow-up too. So you will check in again with the safety plan, see how it's working, and make adjustments to it based on that. If they kind of express some doubt. So what might prevent you from doing these activities? So in the end, you want to end up with what the best, the strategies they actually are going to use. And then, so the next step, social contacts who may distract from the crisis. So who may help you take your mind off of problems, at least for a little while? Who helps you feel better when you talk with them? So what you're really trying to do is like, maybe talk to a friend about like the baseball game that's on TV or whatever, something that's totally different and distracts you. Next step, family members or friends who may offer help. So among your family or friends, who do you think you could contact for help during a crisis? Who do you feel you can talk with when you're under stress? The next step, professionals and agencies to contact for help. So who are the mental health professionals that we should identify to be on your safety plan? Are there other healthcare providers? You might want to put your contact on there as well. So it would be the name, numbers, or locations of clinicians, as well as local urgent care services. And then making the environment safe. So do you, does your family own a firearm, such as a gun or rifle? What other means do you have access to and may use to attempt to kill yourself? So it could be, again, pills in the medicine cabinet, prescription pills. And how can we go about developing a plan to limit your access to these means? And as you'll see, so when the plan actually gets implemented, it's stepwise. So the youth will recognize, okay, I'm feeling that warning sign that I was talking about. And then it goes step by step. So the first thing that the youth would do would be to distract themselves. So it could be like, going for a walk, or walking their dog, or listening to music, exercising. If they're still having that urge, that step didn't work, they go to the next thing. They contact their friend or whoever they listed, and for the purpose of social distracting. If that doesn't work, they go to the next step and they contact those people, that person that they listed on the safety plan as someone they can call and ask for help. They do that. That doesn't work. That's when they call the professionals and agencies to contact for help. And then the last piece is making that environment safe. So if you they have a firearm in the house, making sure that they cannot access that. So it could be that the firearm gets removed or it gets locked safely. So the safety plan, there are apps for this. So the youth, everyone pretty much now carries a phone, their smartphone on them at all times. So they can, as you do the safety plan with them, can actually have them enter the what you guys talk about in their phone while you're there with them. And then they always have that. So if they're feeling, that those warning signs start coming up, they have that safety plan on them. So they can easily download this app. And then for just follow up, it's done different ways in different settings, but it's important to follow up about 24 to 48 hours after initial contact for those who are at elevated risk. So you're pretty much just looking to assess their mood and current risk. So again, you want to go over the CSSRS questions and see if there's any imminent risk. And then, like I was saying, you want to review and revise that safety plan. So what was unhelpful, take it out, identify more helpful ones, and then talk about access to means again. Talk about their engagement. So whether you may or may not have referred them to an outside provider, or them coming to see you. What are obstacles to treatment, and make sure they have information about other community supports, as well as again the crisis text line. And I know I think youth probably prefer that to the lifeline because everyone, loves texting now, prefers to text. But it's also important to have that because sometimes there is a wait between appointments and maybe they need that in the interim. So it's important that they have that on them. And then just making sure that they want to continue with this follow-up and, try to set time, set another appointment, or it could be a call time. And then I just want to bring to your attention non-demand caring contacts, because they're so simple and brief, but yet effective. So it can be, it started off with postcards and letters, then went to emails, but, a lot of people don't even, young people particularly don't use email. So it can be text messages, you see the image there, and it's pretty simple. I mean, it's brief expressions of caring. So you can see on the screen here, "Dear John, it has been some time since you were here and we hope things are going well for you. If you wish to drop us a note, we would be glad to hear from you." So it's an individual, individualized, and you can see like just how simple and cost effective it can be, because there is very positive outcome for people. The main study here was those who refused further care but received these contacts had a lower suicide rate than those in the comparison group. And they also showed, kind of caring text with youth is also effective. And then there are also kind of more in-depth treatment that you may or may not provide. You probably don't provide in the school-based health center, but it could be a warm handoff to other levels of care. So that's like cognitive behavioral therapy for suicide prevention, dialectical behavioral therapy, as well as collaborative assessment and management of suicidality. So these, trainings, some of them actually have kind of online modules. So if you are interested in getting that training and don't already have it, you can, but you can also identify treatment agencies outside of your school-based health center that can provide that. So this is Colorado Crisis Services. I want to thank Gianna for sending this to me. I was very impressed with this service. It's available, at all times, 24/7. The crisis text line is like kind of a national service. This is specific to Colorado Crisis Services. So it's a call and text line. So it's free and confidential, and it covers multiple topics. So it's not just for people who are thinking of suicide or people that have, depression or anxiety. It's for drugs and alcohol, bullying, dating and relationships, school and grades, fights and conflicts, and so forth. All right, so I want to thank you for your time, and my information's up here if you want to follow up with me with any questions. And I think we left 10 minutes here for some questions, so I'd like to kind of open it up if anyone has any questions, or Gianna, if you have anything you wanted to add. before, I know there's this at the end here, but I can take questions first and then.
Yeah,
Go ahead.
I'll let others ask questions first. I have a couple, but you guys feel free to ask any questions you have right now. Well, I'll let you guys think if you have any. Brett, one question that came to mind while you're going through this, I was curious what suggestions you would have for a situation where a student is unwilling to have their family or parents involved, but because they were at risk of harming themselves or had a plan, kind of had to facilitate that. What would you suggest?
Yeah, so, with suicide, like, if you're at risk of harming yourself or others, like there is like the mandated, I mean, I don't know what the policy is in Colorado, but there is like mandated reporters. So they would, I mean, it is, even with substance use prevention and SBIRT model, it's like best practice to bring the family into it. And it's critical to bring the family in. I think it takes kind of motivational interviewing skills to, because you really don't want to do it against the student's will. You want them to be, okay with it. It'll make a better relationship with between clinician and patient. So you want to kind of motivate them and say, what the importance is of involving the family. And I would want to find out kind of what their hesitation is and how they can kind of address that to, move forward. So I think that would probably be kind of the steps that I would take. But, eventually if there is a risk, that they would have to be informed.
Thank you. Any other questions for Dr. Harris? Feel free to unmute yourself if so. Well, I have one other question, but I want to give you guys a chance, so feel free to hop in if you have any. This was actually a question from one of our colleagues at Peer Assistance. What would be some considerations when assessing risk and providing a BI to a young person that identifies as BIPOC or Black, Indigenous, or person of color, or LGBTQIA+.
I think, when we look at the kind of the overall demographics, we kind of see this as, an issue in among the white population. And I think that, what I didn't get into is that we see with youth, we don't have a lot of information on LGBTQ kind of across the board, and adults, we have much more, we're focusing in on youth. And so LGBTQ youth, and then also Black youth are at increased risk. So Black youth suicide's been increasing, and that's been drawing a lot of attention. So these are definitely, that's a very central question that we need to, in terms of how to work with them. I think one, it's always important to, I don't know kind of what demographics are, around Colorado and, the staff, but having like, people that identify, maybe that they can relate to. And, I know that they have kind of the safe space, if you have one of those kind of on your door for LGBTQ, kind of knowing that you understand, what that's like, and being able to have that empathy, and also to be able to provide specific resources. So like the Trevor Project, and integrating that and making sure that they have that, and also knowing kind of what the resources and programs are, at their school. So maybe there's like, a club or a different, way they can connect with, people that they identify with, because, more and more people have, even if you're, a Black youth in an all white community, and that's what you're used to, you still want to connect with people like you. So being able to figure out how, like what those resources are and be able to connect, I think knowing that. So the opportunity for, you know, like, so the SBIRT model, I always like to say it's an opportunity that RT referral, it's not just referral to treatment, it's like referral. So you have an opportunity not just to refer to like substance use disorder treatment, but to all different kinds of like programs and activities. So knowing what those are, is there, you know, an LGBTQ, you know, drop-in center that they can go to that has different, you know, programming. And I know we have some, you know, locally to where I am that we're in, you know, we're working with it with suicide prevention, and they're getting training, and they're, you know, doing these more upstream interventions. So I think that's kind of, you know, really critical there. And then just kind of understanding, you know, what's currently going on. So we know all the stuff that's going on, you know, with the racial injustice, and just being completely understanding of that, that can be causing increased levels of stress, and anxiety and depression and just and anger, all these different feelings. So there's a lot, I mean, there's so much involved in, you know, in kind of identity. So I think that's just really important to understand when conducting the intervention.
Thank you. That's super helpful. We have a couple minutes left, so I'll just leave it open for any additional questions.
I have a question. I'm sorry for the background noise. Any thoughts on addressing a student who, or a kid who we think screen no, you know, perfect on the screening, but we really have some concerns. Either we've heard them from the school counselor, or we know that there's been some history that they're not talking about. Any suggestions for how to gracefully and sensitively address that situation?
Yeah, so, you know, we always say, like, you know, they answer, you know, yes to questions, you know, 3, 4, 5, you know, down, or like 4 and down, that's, you know, a positive screen. But we always say it's important to use clinical judgment as well. So if it's definitely a young person, or anyone can not answer truthfully. And if you feel that there's something there that they're not expressing, or that they may be at risk, that's your clinical judgment, and you should move forward with the protocol. There's also, I didn't get into it, but there's also kind of, you know, suicide risk assessments, which get more in detail into kind of risk and protective factors. You could, you know, start getting into that as well. And also, you know, kind of talking about noticing things, right? So, you know, they answered, you know, these this way to these questions, but I also noticed that, you know, you were, you know, you were doing really well in school, but your grades have started dropping, or, you know, you're not as, you know, social, you know, connecting as much with your friends, or being as kind of social as I'm used to seeing you. You know, a lot, and then looking for other things like, you know, changes in kind of dress and appearance, and different things like that. Like, you can bring that up. There's only so much that, you know, they can just say no, and continue to, you know, not be truthful. But there are kind of different ways to kind of get it. It's best to kind of get it out of them before kind of taking other action. So that's kind of what I would recommend.
Oh, I was gonna say we may have time for one more question, but it looks like it's 1 o'clock. If anyone has additional questions, feel free to reach out, and can help answer any other questions you might have. It's like we do have one in the chat box. Yvonne, we can stay on past 1 and answer your question, but just wanted to let everyone know, if you could please complete the post survey that I'll also send via email, that would be wonderful. And thank you so much, Dr. Harris, for a wonderful LCS. So we'll be staying on for a couple extra minutes. Thanks, everyone.